the barriers and challenges of development in critical care medicine in Mongolia's rural hospitals. General introduction of Mongolia. Mongolia is a landlocked, lower middle-income country in Central Asia. It is a home for approximately 3 million people with life expectancy of 69.3 years at birth. Emergency and critical care medicine is a young medical specialty in this country. The care of acutely and critically ill patient faces serious limitation in human and material resources. The very first ventilator-Engestrem 300, implemented in Mongolia in 1969 in a cardiac surgical center. Since that, the critical care and intensive care medicine started to develop in Mongolia. So this is a picture, black and white, done in 1978 in hospital number 1 in ICU. So we can see that bed rank made by hand, installed oxygen flow, light, some plug-in, and there was installed also the button one can call the nurse in the telephone, which the patient can contact the relatives. There are also a small box to bring blood and blood product. Very old Russian refrigerator. So the facilities looks like this, and we called it an ICU, and we used the very red rubber gastric tube. It's have to see. So this is a 40 years later in ICU, same ICU department. The conditions changed. The countries developed in the ICU, and critical care is also developed in this in Mongolia. In a publication 2018 by Jason Poir and other authors, critical care bed capacity in Asian countries and regions, cross-sectional study, published that in Mongolia there are 12.44 beds per 100,000 population in Asia. It is a quite good number against the average 5.7. But the quality is much different than in Singapore, sure. But it's always issues to keep the numbers and the qualities together. And we reached at first a number, and then we will increase the quality day by day, step by step. In Mongolia, there are 3 levels of healthcare in this country. The first level is primary health care. This is a very small hospitals in a Soum, like a village, or Soum is a larger village, and the nomads surrounding this village. This primary level is to care the people who live in a rural area. The secondary healthcare is in the province centers. There are general hospitals where we can operate and where we can make a cesarean and other trauma care. And this kind of settlement, smaller town, we are having a 20 around this country. In a tertiary healthcare, there are larger multi-professional hospitals, mainly in a capital city, Ulaanbaatar, and the other 1 or 2 major cities that are very rare in Mongolia. This is 3 level which we have in this country. The emergency medicine is a component of primary care. It is included in a primary care since WHO written in the report 2008, and the emergency care, emergency department is inevitable, indispensable part of primary care. The Mongolia had more than 300 Soum, and it means we have more than 300 smaller local rural hospitals. So the issue is how we increase the critical care in these smaller hospitals, and how we increase the care of the rural population, including nomads in Mongolia, is one of the challenging issue for Mongolia healthcare, especially in acute care system in Mongolia. The population which can reach the emergency care in a help in 2 hours, there is only 83.6. The remaining 70% of population, mostly nomads, are not available to reach the emergency service, at least not in 2 hours. So in Sweden or in many other European or Western countries, this figure shows 99.8 or 9. Nearly everyone can reach the emergency care, emergency room in 2 hours. So this is because of also country specificity and country service. And Mongolia is a huge country and very sparsely populated. So we think the current condition in critical care in low middle income countries, including the Mongolia, is the condition is that the critical illness results thousands of deaths in each year, and care for those with critical illness is often neglected because of the lack of access, because of low prioritizations, because of low coordination and coverage of timely identification, basic life-saving treatment in a smaller first-level hospitals. And that's why we say critical care is stepchild in clinical service, at least in Mongolian healthcare system. So specialty of acute care in rural Mongolian healthcare are, first of all, those are critical care, critical service delivered by GPs in the critical care service. The felchers, it's like paramedics. The felchers, paramedics are one of the main human resources also in the rural area. Nurses and felchers run the majority of the care in these smaller hospitals. And resource is also restricted, limited. That's why the critical care is more challenging in these smaller hospitals. So patients are also specific because the patient access to critical care are limited because of geographical distance and barriers, because of the patient's culture. So patient flow with critical condition are low. It makes specialty also for smaller hospital. When was one critical patient arrives, those are very sick with a high risk. Critically ill patients comes at arrival seldom, but when one comes, it arrive very sick. It makes that challenging for local doctors and nurses. Um, there are limitations because of human capacity, education, training, shortages in supply, drug, and equipment. All those are limited, make a limitation in a critical care for those rural population in a smaller hospital. We did a survey in 2017. Through this, we did it in 74 primary level hospitals, and there was available only 62.2. There was a small room or area or corner dedicated for emergency care or rest station. More than 30% of them, there was not in this kind of facilities in this smaller hospital. Mortality in this hospitals, there was ranging 24, 25% in this smaller intensive care rooms. It was published in a British Medical Journal in 2017. The most common cases which we face in rural hospitals, there are trauma, 20%, acute abdomen, which we need to operate, 16, heart failure, brain trauma, 5, stroke, coma, and other conditions. So looking on these figures, the trauma is nearly 25% altogether for mortality as a mortality reason in Mongolia. The common procedures performed in rural hospitals are wound care, burn wound care, foreign body removal, oxygen application, advanced cardiac life support, airway management. The fundamental on sustainable progress, critical care in rural Mongolia are implementation, development of critical care medicine in rural health care of Mongolia. So in the rural hospitals, we need to implement essential emergency and critical care issues. When we say essential emergency care, it means to provide, to deliver emergency care in a low cost with the most basic level of equipment, drugs, and approaches, and to deliver most efficient emergency and critical care in these settings. The specialist, general physicians, felchers, nurses have to be trained in a simple approaches, with simple drugs, with simple technologies to reach the available level of care, the critical patient in a day condition. They need to intend to deliver for the patient irrespective of age, gender, underlying diagnosis, medical specialty, and locations. It's a basic equity in healthcare in a rural area, including the nomads in Mongolia. In those small hospitals, the patients are treated in these hospitals. If the condition deteriorates, if the parameters, vital signs, destabilize and reach a certain level, they need a basic, as we call here, essential critical care in these hospitals. It is written in these resources. So therefore, to develop essential emergency critical care is a fundamental approach to develop the emergency care in rural hospitals in Mongolia, as well as in a low middle income country. The advanced emergency and critical care is a next level of care and even tertiary level. So we work, we concentrate, we deliver the projects in frame of essential emergency, critical care level. That's the main point, main target of our Mongolian emergency essential care policymakers' target point. The barriers and the steps to improve essential emergency care in Mongolia is the low skill of the doctors on identifying the critical illness. Lack of commonly used the guidelines appropriate in a primary hospitals to deliver the essential emergency care. The need implementation, the essential technologies, very basic technologies in delivering essential emergency care in a smaller hospital. The backing up the cost of expense in this care, including the local government to prioritize to make a budget on this local hospitals expense in emergency essential cares. Coordination the emergency service, smaller hospitals, next level, larger hospitals are also issues in a whole healthcare system in this area. What we can improve at first. So we need to improve advocacy on prioritization of acute care service in rural environment, capacity improvement with diagonal approaches, which we include government, local budget funding, as well as international teams and supports. More nurses driving protocols, more health driving protocols and checklists to need to work out. Change the legislation with regard to what GPs, doctors can care and can deliver to this critically ill people. Improve the patient safety and culture. Patient safety awareness in the smaller hospitals, in the local rural hospitals. So we need to increase the level of infection control in a smaller center, as well as training the critical care providers. Work out the appropriate textbook, guidelines, standards, based on their need, on their special conditions. Build up the structured training and courses like BLS, ATLS, ALS. Jobless training, mostly when we go out to the rural hospitals, we work with them together, operate together, and open the smaller operating room, functioning surgical care, and appropriate acute care settings too. The task sharing and task shifting issues are also one of key issues to improve the capacity of essential emergency and critical care in a rural area too. Without task sharing, it's not available to cover all the capacity needed. To prevent the de-skillization, current doctors and GPs or nurses in these forgotten rural hospitals is also issues, and then that's why I need to make a rotation exchange with the specialist in a province central hospitals. We started World Health Organization's project named Essential Emergency Surgical Care since 2004, and we mobilized the support from Swiss surgical team, Australian aid, and American College of Surgeons, Australian teams in a variety of acute care teams like KBL initial emergency care teams, which we run also with the support lab box and Italian doctors in a variety of countryside to make the critical care, surgical care in a different level, in a better level. After 10 years of this project, we were able to consider that as a WHO collaborating center on essential emergency critical care and essential emergency surgical care since 2013. And we worked again 5 more years, and we reached quite a good outcome because we were used the resources from local and government level, and we used a best example, best practice, and also fundraising from this international communities, and then reached the quite good reached a quite good number of indicators. For example, Lancet Commission Global Surgery. There are certain indicators of sustainable development goal is already reached on this target for 2030 is already reached in Mongolia right now, but we need to improve these figures and the qualities to reach the universal health coverage goal for global community. So if we implement essential emergency critical care program well in Mongolian healthcare, it will progress the healthcare service for Mongolia, especially for nomad population of Mongolia. To reach this goal, we need to take in a policy like a system-wide approach for managing critical illness, equally in a rural and in urban areas, approach that could prevent the deterioration, the clinical condition of the patient, also save the lives at a low cost. Critically ill patient would be identified and treated quickly on the place throughout the rural hospitals, the rural conditions and resources. As a conclusion, I would mention essential emergency critical care should be a crucial part of universal health care coverage, and as well as emergency essential critical care has had the potential to improve the care given to critically ill patient in rural small hospitals. Emergency critical care has a substantially reduced parental mortality in rural hospitals all around the low, middle income countries. Thank you for your attention.